to actually invite radiation oncologists to start a very fruitful head and neck session. So today my job here is not to share with you the advances in radiotherapy, but instead one of the most dreadful complications or late event that we see in our NPC survivors. So second cancer, in fact, in head and neck cancer is a recurring event that we normally see in our follow-up clinics. It's actually very common that account for approximately 1/3 of all late mortality in head and neck cancer patients. In the setting of head and neck squamous cell carcinoma, the number of patients that we need to observe for 1 year to detect 1 second cancer is as low as only 60. And in the diagram over the right side, you may see that second cancer for head and neck squamous cell carcinoma survivors, the incidence is increasing over the past decade, perhaps with the exception of oropharyngeal cancer, which coincides with the HPV positive era. So for head and neck squamous cell carcinoma, it was estimated that patients, the survivors has approximately 2 times risk of subsequent cancers as compared to the general population. And these excess cancer risk actually focus in the upper aerodigestive tract, namely the lung, the head and neck mucosas, and also the esophagus. This is largely attributable to the common etiology of smoking, tobacco smoking, that lead to field cancerization. But when it comes to nasopharyngeal cancer, this is slightly different. First of all, in the endemic area, we know that the smoking prevalence for NPC patients are generally lower, so the field change is also less. However, on the other hand, radiotherapy remains to be the key treatment for these patients. So radiation carcinogenesis is a huge problem. And NPC patients are typically younger and their prognosis is ever improving. So they have more time to develop second tumor as well. Before I jump into the incidence of second cancer, I would like to highlight to you 2 different types of radiation toxicity. The first type is called a deterministic effect, such as dermatitis or mucositis. These complications occur only when a certain threshold of radiation is higher than that. For example, for the neck region, we do not normally see skin changes as long as the radiation dose is less than 10 gray. But after that, we can see a clear dose sigmoidal relationship of dose toxicity relationship. On the other hand, second cancer is slightly different. There is some degree of randomness inside. First of all, this is a stochastic event, meaning that even at the very low dose of radiation, this can also occur. And also, even in patients who receive no radiation, there is a certain degree of background incidence. So the prediction of this event is quite difficult because of the randomness of these characteristics. One of the largest series actually published in a Taiwan group more than 10 years ago. They have performed a population series trying to look at over a 25 years period, the development of second cancer in their group of patients. And on the diagram over the right side, you may notice this incidence, the crude incidence actually increases slightly in a gradual way since the diagnosis of NPC up to approximately 5.4% at 20 years. Interestingly, they try to compare this cancer risk with the general population, and they reported around 24% increase in cancer risk and compare with the general population data. And these cancer risks focus in the oral cavity, the major salivary gland, sarcomas, skin cancers, and also, surprisingly, leukemia. But now, after 10 years has passed, there are advances in radiotherapy that we are using right now. In the old days, over the left side, we are treating patients using a deep fried approach. We treat the nasopharyngeal cancer using simple field arrangement. You can see that a lot of the soft tissue area is covered by a very high dose of red radiation. But now we are moving to the right side, the intensity-modulated radiotherapy. With this technique, we are able to conform the high dose radiation to only the nasopharyngeal tumor, thereby preventing necessary toxicities to the brainstem or the parotid gland. However, as you may notice, the entire head and neck region is now immersed by a low dose radiation bath. And this is particularly worrying because second cancer could occur at this low dose region. And apart from that, in the old days, we shape our radiation field using a very heavy lead blocks. But now over the right side, we are using these metal plates that is called a multi-leaf collimator, which is constantly moving during the treatment to shape the conformality of the radiation. Although these are very sophisticated designed, but then there are tiny gaps between these plates that can actually leak radiation to the patients. So the scattered dose is also higher. So because of these, the Hong Kong Nasopharyngeal Cancer Study Group has tried to converge and analyze the incidence of second cancer in the intensity-modulated radiotherapy era. What we have done is that we followed 3,300 patients treated in 2001 and 2010, and include all 6 public oncology centers. And over a median follow-up of 10.8 years, we observed 290 second primary cancer, 40% of which occur within the head and neck region, which is quite a lot. The crude SPC second cancer incidence is as high as 9.2%. And over the diagram on the left side, there are plotted 2 lines. The dotted red line is the expected population incidence, and the blue solid line is the observed incidence in our cohort. You may as well notice that this line started to diverge at the year of around 5 years. This is exactly the latency requirement for radiation-induced carcinogenesis, and you may expect this line to diverge even further if this line extends to around 20 years of time. And what we have done is that we try to match our patient characteristics with the Hong Kong Cancer Registry data and estimate the excess cancer risk as compared to age and sex-matched general population. Our study observed that there are 90% increase in cancer risk in our NPC survivors, and these cancer risks focus in a few subsites, particularly for oral cavity, the head and neck skin, oropharynx, thyroid, salivary gland, and nasal cavity, etc. I would like to draw attention to the number for the oral cavity. It was 26. In other words, there are 26 times more likely for NPC survivors to develop a subsequent tongue cancers compared to you and I. We also perform a subgroup analysis, trying to stratify it by the age of diagnosis and also the follow-up period. In relative terms, younger patients are more at risk of developing second tumors because they have less competing risk of other cause of death. And also for patients who are more than 10 years into their survivorship, their relative risk is also increased a lot. When it comes to cause-specific mortality, you can see that in the green line, that is NPC-related deaths, you start to get a plateau after 5 to 8 years. However, the red line is creeping up. That is the death from second primary cancer. In fact, at 10 years' time, second cancer constitute approximately 10% of all deaths in our patient cohort, which is quite significant in my opinion. So I would like to talk slightly into the tongue cancer that is found after radiotherapy for NPC. During our preparation of this study, we observed a very interesting phenomenon, is the change in topography. In the past, in patients treated with 2-dimensional radiotherapy, the tongue cancer tend to occur in the dorsal side of the tongue and also the base of the tongue. But now with IMRT, we are now shifting the topography to the lateral edges. And the reason behind is like this. I'm not born in these days, but I observed this data, this diagram from my old journal, and it was shown that the red box is our radiotherapy field in the past. And you may see, appreciate that the base of the tongue and also the dorsal tongue are within the cross-firing zones. But now with IMRT, the tongue is largely spared and the low dose or intermediate dose has shifted to the lateral edges. And that's the reason why we're seeing topography changes in radiation-associated tongue cancer. It also highlights the concept of sublethal radiation damage because radiation-induced cancer is very interesting. For example, in this area of red very high dose of radiation, most of the cells are killed, so they don't have a chance to develop second tumors. On the other hand, in these low radiation or intermediate radiation zone, the cells is able to accumulate enough mutations and then to develop into carcinogenesis later. And on this, we try to perform a pilot study, trying to compare whether there's differences in clinical pathologic characteristics of radiation-associated oral cavity and also sporadic oral cavity cancers. Generally speaking, after radiation, the oral cavity cancers has a much lower rate of nodal positivity, which is due to lymphatic atresia in the neck after radiation. And pathologically, upon independent pathologic review, we do observe more aggressive parameters for post-radiation oral cavity cancers, such as a higher number of perineal invasion, more WPOI5, and a higher number of tumor budding. And in terms of relapse-free survival, radiation history remains to be an independent poor prognostic factor after adjusting for other clinical features. And we also try to analyze a panel of or RNA expression of different kinds of genes, comparing these two groups. And we observe in a hypothesis-generating manner, lower expression, lower RNA level of CD86 and CD80, and also TF-beta. We are working on to understand the meaning behind these findings as well, and we will update you later on that. So in terms of the challenges in managing post-radiation tongue cancer, it's of course difficult because we need to perform surgery on irradiated tissue, and trismus could limit surgical access. And there's very limited room of adjuvant re-irradiation. And also there is a doubt on the response to immune checkpoint inhibitors as well, because recent study has shown that an intact regional lymphatics is important to mount a local response to immune checkpoint inhibitors. So here comes to two slides on post-radiation sarcoma. I just want to share with you this unfortunate patient of mine who was treated in 2010 for a stage 3 NPC. But after 10 years, she developed a right neck mass, biopsy showing sarcoma. At that time, we tried to give some sort of systemic treatment, but essentially this is chemo-refractory. And this young lady died of very severe local symptoms of brachial plexopathy, bleeding, and also edema. Post-radiation sarcoma typically occur within the high-dose radiation zones, and they are usually of high grade with no specific histologic predominance. And these tumors are characteristically very latent to develop. It could occur after 20 or even 30 years after radiation, and are very aggressive as well. And in terms of challenges, the diagnosis is often delayed because it's often easy to mix up with radiation necrosis, and the surgery on complex functional anatomy and heavily irradiated field is challenging. And again, there's limited room for irradiation to the base of the skull. And so what we can do to minimize this complication, I'm afraid that we don't have good prevention except to minimize radiation exposure. And in the oncology community, we are trying to de-escalate our radiation volume and radiation dose as appropriate. And after all, it's more important to be vigilant in monitoring these patients, particularly to check the oral cavity in long-term survivors. And also it will of interest to study whether there's role of chemoprevention. For example, the use of aspirin after these patients, whether we can prevent these tumors. However, there is no evidence in this regard. This is almost my last slide. And of course, we need to talk about proton therapy, which is usually a new technique, a fancy technique that can reduce radiation exposure. As you may see in the right side, if treated with a nasopharyngeal cancer, the oral cavity generally spared because of the less exit dose of this radiation technique. However, there are issues on cost effectiveness that has to be sorted out before usage. So to really conclude, I must say that after IMRT, NPC patients has a very high risk of second tumors, up to 90% higher than the general population. And these excess cancer risk concentrate in the oral cavity, head and neck sarcomas, skin, oropharynx, thyroid, middle ear, sinuses, and also nasal cavity. And these tumors impair longevities of our long-term survivors and of poor prognosis, highly challenging to treat, and early detection remains key. This is my final slide. As a radiation oncologist, I hereby plead guilty to causing this post-irradiation second cancer. And I must thank my ENT friends and colleagues, medical oncologists and palliative care specialists for clearing up this mess for us and take care of these patients. Thank you very much.